A very good afternoon to everybody. Thank you very much for joining today. So today's webinar is on understanding Parkinson's disease. We've teamed up with Dr. Laura Daunt and very much looking forward to learning more myself, and I'm sure you all are, on Parkinson's disease. So I thought I'd just kick off by really running through who we are. So my name's George. I work at Yorkshire Care Equipment, the sales director here. And really what we specialise in is high quality care equipment, but with a particular focus and passion for specialist seating. So our mission is to enhance quality of life, which I'm sure closely aligns to what you guys carry out each day. We've been working with healthcare professionals for many, many years now. We're about to celebrate our 50th birthday in a few months' time, which is exciting, and we've dealt with many thousand professionals, which has really helped us grow and helped us learn and develop. So a lot of what we do, we carry out joint equipment assessments with occupational therapists, physios and others in the homes of clients where they're unable to come and visit us. And we've really spread a lot recently in terms of our equipment is found in hospital wards, many care facilities and private individuals' homes. So I'm just going to run through some of our key products. One that we developed back in 2015 called the Lento care chair. Some of you may have heard and used and had us come out and assess with. So in essence, this is a highly adjustable tilt-in space care chair, so for patients which are hoisted. So really thinking on today's topic, somebody may be end of life with Parkinson's, unable to mobilize themselves. This is where the chair can ultimately follow their line, their condition. Maybe as they deteriorate, we've got a lot of adjustment we can do within the one chair there. And then as part of the family, we developed the smaller little Lento care chair. So this is the same, but just obviously in a smaller version. So not just for pediatric, for children, but also for small adults too. And it works in exactly the same way. More recently, we developed the Lento rise and recline chair. So this again follows the concept of adjustability. So we've got a lot of easily adjustable sections on the chair. So you've got the seat width, the seat depth, the seat height, the arm height, and the back height. They're all independently adjustable without the need for any tools, which really makes it easier for you as clinicians and ourselves to adjust and set up the chair. So we're making sure it's suitable for a wide range of patients. So moving on to our most recent product, so the bariatric rise and recline, again part of the Lento family. So we feel this is the world's first, having a chair so adjustable for the larger patient type. So you'll see there on the screen, users up to 50 stone in weight. We've got a 25 stone capacity on the leg rest. And particularly, as you'll appreciate, with a bariatric patient, their weight can tend to fluctuate. So it's really important having that adjustment within the chair, not just from a seat width, but the depth and a floor to seat height, arm height, and so on. All those things may be needed to be tailored at a later point for the patient. More hospital related now, the ProSpec rise and recline chair. So you'll see there that the chair is fully compatible with the SARA study. Many of you have had that experience when you're using something like a stand-aid assist, that they just aren't compatible with rise and recline chairs. Well, this is. We've got a cutout underneath the front of the arms, which allows the legs of the steady to go under, and then the paddles neatly move over the top of the arms there. It's also portable as well, which for patient types in that in-between stage, so you might say one day they're needing to be hoisted, the next day they are mobile, and that might be relevant to our conversation today in terms of some Parkinson's patients. So we've got the ability here to mobilize them with the assist of the rise function, and or if they're off their feet, we can use a hoist in conjunction with it. So it's really quite a flexible chair which fits a niche. And then lastly, the Prospect Hospital Chair. So this is something we developed closely along with the full teams at Aintree Hospital in Liverpool and Royal Victoria up in Newcastle. Many of you who are seasoned and been in the industry a long time will remember the Flowtech chairs. So unfortunately they went off the scene, they went into liquidation, but there was a big call for them and there was a large number of these in the hospital environment. So we were approached many years ago, probably about 10 years ago now, asking if we could make a chair like this, and that's exactly what we've come up with. So a more developed type of the Flowtech chair, and called it the Prospect. So we've got adjustment from the handset to adjust the seat height, the seat depth, and also the tilt forward and backward. And that's been really, really popular in the hospital environments. Moving on, so more moving and handling and falls related devices. So again, many of you may be familiar with the Razor lifting chair. This is now available as a manual operated version as well as a battery operated version. So just a little bit of detail on this. Sorry, I've flicked over to the next slide in error, but I'll just run through on the Razor. It has what it ultimately does is it means that one carer can easily assemble it around a patient very safely and bring them back from a fallen, so a lying position, to a stand. It's a really sturdy lift. It's lightweight and portable, and it's very, very easy and intuitive to put together. More recently, we introduced the hip guard, which is a belt, a discrete belt that you wear. Very clever in the sense that the electronics in the buckle itself, they detect when a patient is falling, and the airbag on the side that you're falling will inflate, therefore protecting your hip. As many of us know, the actual hip protectors which are worn, there's very little clinical evidence that they prevent hip fractures, and this is really very new and innovative, and we're currently working with some of Dr. Laura's team looking to introduce it as part of a pilot trial with the NHS, so we're very excited about that. And lastly, an interesting concept. So you look at it first of all and you think an office chair, but it's a lot more than that. This is a chair made over in Denmark called the Vela chair. It's used for multiple medical conditions, including Parkinson's. So it's got height adjustment. We can adjust the rake forward and backward, and we can also adjust the backrest and the arm height. And really what it's encouraging is mobility around the home and being able to carry out activities, maybe such as ironing or washing, in a way that you wouldn't be able to do on something like a perching stool. So that's a really innovative product. So that's enough from me. I'm moving on to the main presentation now. A warm welcome to Dr. Laura Daunt. She's a consultant in healthcare of the older persons, and very much look forward to learning more on Parkinson's. Over to you, Laura.
Hang on, now this is the bit I'm worried about, is getting it all working. Hang on. How do I get back? Hang on, I'm going to stop sharing. We are going to talk about Parkinson's disease for 45 minutes. Don't worry, this is me being not technologically au fait, so don't panic.
No worries.
Hang on. There we go. Right, hang on. Got it. And then go back to there. And then go back to here. Okay, can you see a presentation?
Excellent.
Great. Hello and welcome everybody. I'm sorry that there looked like there was lots of stuff going off in the chat. We are going to talk for 45 minutes about understanding Parkinson's disease, so don't panic. My name is Dr Laura Daunt. I'm one of the consultant geriatricians at Queen's Medical Centre in Nottingham. So we're part of the Nottingham University Hospitals NHS Trust. I'm a consultant in healthcare of the older person. I've got a subspecialty interest in Parkinson's disease. So I run one of the Parkinson's clinics at Queen's along with some other colleagues, and I'll talk to you about the setup of the service as we go along. So I'm hoping if I click it, it's going to advance. It hasn't yet, don't panic. There we go. So what I'd like to talk about today is pretty much what you had in the promotional bump, really. So I want to talk about what is Parkinson's disease, what are the symptoms, a bit about the terminology that we use in day-to-day sort of business, understanding medicine. So it seems very complicated, but actually it's not. And I hope to present to you sort of a simplified model of what we're doing with the medication so you can feel a bit empowered with those. Common impairments and how that impacts on on equipment that you might need, etc. A little bit about falls optimization, and then a bit about mental health, but mental health and physical health are very closely intertwined in Parkinson's disease. So Parkinson's disease is a progressive neurodegenerative condition. So we mean something that gradually gets worse. It's a problem in the brain, and it results basically of death of the dopamine containing cells in the brain. Cells die because you get a buildup of protein in them called Lewy bodies. And you can see on my screen there that there's this big abnormal kind of white and purple blob in and amongst everything that looks nice and pink, and then occasional little pink, purple bits. So basically you're getting abnormal protein bits in your brain that are causing brain cells to die. That's what's happening. So dopamine is a chemical, and in posh terms we say a neurotransmitter made in the brain to send messages between cells. So it's how the cells in the brain talk to each other. And there are problems if you have too much or too little. So interestingly, things like schizophrenia and if you take recreational drugs result in too much dopamine. So too much can be bad as well, but too little can cause problems because the cells can't talk to each other. And the cells with dopamine in them are deep within the brain in a bit called the basal ganglia. And the basal ganglia is responsible for voluntary motor control. So by that we mean things that we do voluntarily, physically. So physical things that we're doing under voluntary control. Things that we've learned, so procedural learning like writing, riding a bike, eye movements. So our sort of voluntary eye movements, looking this way, looking that, and cognitive and emotional functioning. So you can see with the part of the brain that's affected, controlling those things, you can start to see how a problem with the chemical setup might lead to the problems that we see in Parkinson's disease. So just to draw a little bit more on the sort of the physiology. So the basal ganglia helps you perform well-learned voluntary and semi-automatic skills. So things that involve sequences like planning, preparing, initiation, and sequencing of movements. And obviously the thing that springs to mind is walking, so you gait. And so functional abilities that are going to be affected by this lack of dopamine are your balance, your walking, your speech, your handwriting, typing, if you're clearly not like me, your IT au fait, fastening buttons, so fine dexterity, driving, riding bikes, anything that becomes automatic. And for those of you that are visual, the basal ganglia is right in the brain. So if you imagine cutting yourself in the middle there, you're looking, and it looks almost, I think it looks like a hearing aid, doesn't it? Which is, again, very applicable, deep within the brain, and that's where the dopamine is produced. And it's, it's got lots of anatomical posh words, but, we call it the basal ganglion if you think of it somewhere deep inside. So the symptoms in Parkinson's disease, interestingly, it's been described for a long time, hundreds and hundreds of years throughout history, as a shaking palsy. But it wasn't until 1817 that James Parkinson wrote essays on this sort of condition that encompassed a tremor, bradykinesia, so that means slowness of movement, stiffness, and postural instability. And he was called James Parkinson, hence Parkinson's disease. So what do we mean by all of those things? So a tremor, so a shake, so it's an involuntary movement. And the interesting thing about a tremor is not everybody has to have a tremor to have Parkinson's. So only 70% of people will have it, because you think, oh, Parkinson's, someone's shaking. Not always, actually. And it's a resting tremor initially. So it'll be people that say, well, you know, my husband or my wife or whoever is sat there watching television, and I can see their hand going. I can see their hand shaking. It's not, I'm passing you my cup of tea and I'm going to spill my cup of tea. That's probably something different. The other interesting thing about the tremor in Parkinson's is early on is that it's under voluntary control. So if you say to somebody, oh, look, you're shaking, all of a sudden they'll stop. And then when you distract them, perhaps get them to count 20 to 1 or you know, do serial sevens backwards, all of a sudden the tremor starts to come out. And if they're doing something, at least in early stages of the disease, they can pass you a cup of water and they won't spill it. And things that shake are your hands, usually, your arms, legs, feet, and your jaw. Your jaw is a really specific tremor to look for when you're looking in diagnosis. It tends to be, and again, another interesting thing is that there's usually one side worse than the other in early disease. As time goes on and as years go by, it does tend to become both sides, so bilateral. But in early disease, people will say, oh, look, my left hand just isn't doing what I want it to do. And I just noticed I've got this shake. And we call it a pill rolling tremor. So it's like rolling a pill between your thumb and your forefinger. And it's sort of like this. It's a very distinctive thing. Once you've seen it once, you won't forget it. So that's your tremor. Not everyone has to have it. It usually starts on one side. It's this pill rolling in nature. The second thing the only thing that you have to have, I said you didn't have to have a tremor, you have to be slow. So we call it bradykinesia, and there are sort of special ways that we assess for it. And the main one is we get people to finger tap like this. So tap your thumb and forefinger together. We get you to do it more than 10 times. And what people with Parkinson's do is they slow down, and it also gets smaller. So that's bradykinesia, slowness of movement. And if they can't do that because they've got arthritis, sometimes you get them to pretend that they're turning a door handle. And sometimes you just have to be a little bit sort of subjective in the way that you assess that, depending on the patient's abilities. The other thing that you might find people are stiff. So we tend to, again, assess it in the upper limbs initially. And you sort of feel at the wrists whether you can feel something called cogwheeling. So it's like, turning a cog, it goes dum, 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 down throughout the range of movement. And that is a slight tremor combined with rigidity of the muscles. So those are the cardinal physical symptoms. And then remember we talked about the basal ganglia being responsible for gait. So people with Parkinson's are exactly as they are in the picture that I've just got there. So with time, people complain of being stooped. You take small shuffling steps. You can be really quite unsteady because you lose your postural reflexes. Sometimes when you stand up, your blood pressure plummets, you go all unsteady and wobbly. And then people have this tendency to retropulsion. So that means you get forward momentum, and then you keep getting it, and you keep getting it, and you keep going and keep going, and then you sort of run and keep going and then fall over. So you sort of almost lose your ability to brake. In very early disease, and something again when we're looking at diagnosis, people lose their arm swing. Now you try and now I've said this, it's tricky when you say to people walk normally and you've got loads of people staring at you, but when you walk, you swing your arms naturally. It's quite difficult not to swing your arms. So when we're looking at somebody that might have a tremor, or we think they've got Parkinson's, watch them walk and see what they're doing with their arm. And sometimes it's just the affected side, that unilateral presentation, that doesn't swing. As disease gets more, as it progresses, people have difficulty turning. And they get stuck. So they get stuck on thresholds. So again, your brain's sort of receiving all this input from perhaps a change in flooring or a crowded corridor with furniture. The brain goes, what's on earth is happening? Your brain isn't signaling to the cells next to it to say move, you freeze, you get stuck to the floor, and hence then people fall over. Now, the unspoken trouble in Parkinson's disease is actually the non-motor features, so the non-physical bits. These are actually the bits that I probably spend most of my time trying to help, because these for the patients are actually some of the most debilitating problems. and perhaps, you know, less is spoke about. So up to 60% of patients will get depression. And this is because, as you can imagine, if cells are dying off in your brain, although they're largely dying off in the dopamine producing center, other cells will die off as well. So noradrenaline and serotonin, which are responsible for your happy chemicals, basically, are starting to die off as well. So you get chemical depression. Dementia, so up to 75% of patients will get dementia. So when I said there's a big overlap between sort of psychiatry and ourselves, that's why, because if you have patients on your books long enough, 3/4 are going to get dementia. They get something called REM sleep behavioural disorder. Now, in REM sleep, that's when we dream. And we are paralysed, because obviously if you're dreaming about being chased by a tiger or a lion, you don't want to be thrashing out and sort of, you know, hitting the person next to you. But in Parkinson's disease, interestingly, some people don't have that, and they do. They lash out in their sleep, they speak in their sleep, they shout out. And sometimes this can actually be before you develop Parkinson's disease. So if someone comes to you and says, oh, gosh, I act out my dreams at night, you've got to keep a very close eye on them, because in about 50% of people, in 10 years, you'll develop Parkinson's disease. Other things, constipation. So almost everybody gets constipated because your gut, everything slows down, your gut slows down. Restless legs, again, can be really debilitating for people when they struggle to sleep. And again, restless legs, we think there's sort of some basis in lack of dopamine. People get pain, you get postural hypotension, so your blood pressure is dropping when you stand up, which we just said before. You get urinary problems, you get frequency, and you get psychosis, so you hallucinate and you can get really quite delusional. And then other things that we might look for in the presentation. So you get reduced blinking and what we call hypomania. So mask-like face, so people lack expression. And this is something that the family will comment on. They say, oh, do you know, actually, you know, my father and my mother, you know, when they just don't look so full of expression as they used to. And people might say, oh, my writing is getting smaller. And the thing about the writing is that it starts off normal, but then it gets smaller. Everything gets smaller. So we're doing this tapping of your fingers. The movement gets smaller. The writing gets smaller towards the end of a line. Your voice, people might start off okay, but then towards the end of a sentence, you get quieter. And another interesting thing, again, based in pathology, is that a lot of people lose their sense of smell. And this is non-COVID related. Nightmare when COVID came out and you lost your sense of smell. But people with Parkinson's don't smell. And there's a theory that the Lewy bodies are sort of starting in your center of smell and then marching out into the rest of your brain. So a bit of jargon busting. Neurodegeneration we talked about. So this is your brain deteriorating because the cells are dying. Motor symptoms. So we use motor to mean physical symptoms. So what are your physical bits? And then we use the non-motor to describe the non-physical symptoms like the depression, the constipation, dribbling, mask-like face, etc., etc. Postural instability. So that usually relates to anything related to walking. So falling over, blood pressure dropping when you're standing, being really unsteady. Often you'll hear us described sometimes in clinic letters about off and on phenomenon. And this is something that patients really relate well to and like using this terminology. So what happens as time goes on is that when we give people drugs, so we give people dopamine to help the cells in the brain talk to each other. And what people find is that sometimes that they feel those drugs work and they're on it. Physically, they're loads better. Perhaps their non-physical things might be loads better. But then as the drugs start to wear off and you sort of drop below this therapeutic kind of level, everything switches off and your brain can't talk, bits of your brain can't talk to itself again. And all of a sudden your walking gets terrible and you get stuck. And people say it's almost like switching a switch. I'm on, I'm great, I'm all right, I can do something. I need to be able to do what I can do at 10 o'clock in the morning because I know I'm going to be good. And then I know that perhaps an hour before my tablets are due, the switch goes off and I can't do anything. A bit related to this, so we said that we get what's called freezing. So this is, again, once you've seen it, you know exactly what I mean. So patients walk and it's literally like being stuck to the floor. So they can't get going and you get this problem with, we call it gait initiation failure. So they physically can't walk and you get this sort of stuttering movement where the brain's kind of going, come on body, come on, do it. And you can see almost that it's not connecting up. And then finally, the movements that we talk about, I call it the fidgets to patients. So dyskinesias, again, are something that happen in later disease, where people get really almost, you get these kind of writhing movements. Sometimes they can be subtle, but and you can just think, oh, is that person fidgeting? Or have they genuinely got like this movement where they can't sit still? And sometimes it gets so dramatic, people fall over or fall out of chairs. And this is again related to the dopamine drugs that we're giving people. It almost gives you extra movement. You almost overshoot the deficit, and you're giving them too much dopamine that gives these extra movements. So those are the jargon bits. The other thing I want to talk about, because you may come across people who have Parkinsonism, but not Parkinson's disease. Now, this is where it gets a little bit more tricky. So Parkinsonism is basically a syndrome where people have symptoms, so physical symptoms like they've got Parkinson's disease, so like their brain cells are dying off, but it's not caused by Lewy bodies getting into the cells and killing them. It's caused by other things. So you can imagine that if you've got lots of little strokes deep within your basal ganglia that are killing off cells because they've got no blood supply, that you're going to get symptoms similar to Parkinson's, but it's not due to lack of dopamine, it's because you've had no blood supply and the cells have died because of that. Drugs, so particularly antipsychotics, so drugs that you use in syndromes like schizophrenia, psychosis, where you get too much dopamine. If you're giving a drug that blocks dopamine, you're going to look like someone who's got Parkinson's disease because you block the dopamine. Parkinson's disease is also a spectrum. So you get some people who have quite mild symptoms, and obviously it progresses, so that might change. But we've got these syndromes called Parkinson's plus syndromes, and those are basically really, really bad. So there's a thing called multi-systems atrophy and progressive supranuclear palsy, and those are two entities that you have symptoms like somebody with Parkinson's disease, but actually you progress quicker. It's all really debilitating, and your life expectancy is much shorter. So not a bit of a nasty, really. And then Lewy body dementia. So again, on the same spectrum as Parkinson's disease, but you tend to get your memory problems before you get your physical problems. In Parkinson's disease dementia, you get your physical problems first, and then you get dementia later on. So remember, I said 75% of people with Parkinson's develop dementia. So a little bit about your prevalence and all of those things that it's nice to know but not expected to remember. It's common. That's all you need to know, is it's common. And it's the most common neurodegenerative condition after Alzheimer's. So you've got incidences and prevalence of that. You just need to know it's common. And it's a disease that is getting more frequent and is associated with getting older. So you can imagine that as a geriatrician, we're seeing more and more. We're getting an aging population, we're seeing more and more. And it affects 2% of people over 80 and 10% of people in care homes. Now that's a big number. And that's because the impairments that you get become so debilitating that often care at home is tricky. Not impossible, but tricky. It's slightly more common in men, only slightly. And the lifetime risk of all of us here is about 1 in 37 people. So that's a lot, there's 300 people on the call here. So chances are that several of us may well end up with Parkinson's disease in later life. What causes it? So the answer is nobody knows. If only we knew, that would help obviously direct causes, cures, etc. What we know is it probably is a mixture of things. So we have isolated genes that will put you at higher risk, and there are certain genetic subtypes that cluster in families, but these are rare, and these are people that are getting the disease in their 30s and 40s, so much younger people, and it becomes quite noticeable for the sort of age of onset, really. We know that there are environmental factors, so we know that working with certain chemicals, working in certain farming environments can increase your risk. We know it gets more common with age. And interestingly, nicotine and caffeine are protective. So we can have a morning coffee without feeling guilty about it, but not a morning cigarette, because that does bad things to you. So a little bit about our movement disorder service at the hospital. So we're very fortunate. We have a big movement disorder service. We have an awful lot of patients, somewhere in the region of sort of 5,000 patients on the sort of clinic books. And we're also, again, very lucky that we've got 3 consultant geriatricians, so myself and 2 others, and we've got 2 consultant neurologists within that clinic. We have one big Wednesday morning clinic, and we sort of, if we think neurology would be better looking after somebody, perhaps somebody that's younger, that's got more tricky symptoms that might need some sort of advanced therapies, they might be under neurology. If patients are older and they've got lots of other comorbidities or lots of other drugs, then they tend to come to us in HCOP, we call it healthcare of the older person. Referrals tend to come from primary care GPs, but actually increasingly from community matrons, care home teams, therapists, and actually the nice thing, we've got a relatively large community geriatric service. So we've got a couple of prongs that sort of can lead to patients being referred into hospital, or even sometimes going to see them out in the community. We've got 4 Parkinson's disease nurses, and we've got 1 in the community. I mean, it's very telling, isn't it, that we are in a massive city and we've only got 1. So this is something that we really need to work on. I think a lot of community matrons shoulder the work, and certainly other other allied health professionals. And then we've got our community geriatricians that we link in, who again do, we worked out probably about 30% of the workload is patients with Parkinson's disease. So within clinic, we get the referral, we see them usually in the hospital, and there is no test that will tell you whether you've got Parkinson's disease or not. There is no blood test, there is no scan. So it's about your clinical judgment. So it's about looking and asking about all of those symptoms that we talked about, and assessing them for stiffness, for slowness of movement, looking at their walking, looking at their arm swing, looking at the drugs that they're on. Are there some other drugs that are blocking the dopamine and it's not actually the cells dying off? And occasionally we might do a couple of scans. So a DAT scan, so a dopamine transporter scan, looks at the level of dopamine in your brain. Now, the reason that this isn't diagnostic is there are other things in your brain that can lead to dopamine reducing. So again, if you've had lots of strokes or you've got an aging brain, it might be abnormal anyway, so it's not helped you. But if you're younger, then certainly you probably want to do that to back your diagnosis up. And then sometimes we do an MRI, so the one where you go in the tunnel, the magnetic resonance imaging, to look at the deep structures in the brain. Are they shrinking? Is there some, what's the kind of, have they had lots of little strokes? Is there anything else that's going to be revealing? And just because they do very pretty pictures, this is a dopamine transporter scan. The top ones are normal, so your basal ganglia, I said it looked a bit like a hearing aid if you chop yourself down the middle. Well, if you chop yourself that way, then it looks like a comma. So like you have in, when you're writing a comma, and as it sort of dies off and the cells start dying off, they start dying off at the tail of the comma, and you end up with 2 full stop like looking kind of circles. So that can help you support your diagnosis. So that's symptoms. That is how you kind of come into clinic and diagnosis. So a bit on the medication. You're lacking in dopamine, you're lacking in the chemical that's helping your brain cells talk to each other. So how are you going to try and fix them? You're going to give them dopamine. And there's only really 4 ways of doing that. So you can either engineer a dopamine type drug in the lab and give it in a tablet form. So we're trying to increase the level of dopamine in the brain. The other way that you could do it is that dopamine is acting on different receptors in the cells and sort of activating downstream pathways that are going to help you move and the brain cells talk to each other. So you can formulate a molecule that's going to sit on that receptor and activate it and activate all those downstream pathways, and we call those dopamine agonists. Dopamine, when it's being produced and it's hanging around in the brain cells, is it gets broken down, otherwise it'd be there forever. And it gets broken down by 2 different enzymes. So you could inhibit those enzymes and stop the dopamine being broken down. And that is it. Those are the only 4 things that you can play with in terms of your armory of medication. And if you're visual about this, this is what one of the brain cells looks like. So you've got what we call L-dopa, so that gets converted into dopamine, and then it gets spat out by the cell at the bottom, and then it communicates with the other cell with all the dopamine kind of floating across the the cellular space. So how are you going to give people dopamine? You're either going to give them synthetic dopamine, you're either going to give them something that activates the receptor, or you're going to stop it being broken down. Those are your 4 things. That's it, which is why, although it seems horribly complicated and patients with Parkinson's disease can end up on 5, 6 different tablets at different times of day, actually, on a sort of cellular level, if you kind of bring it back to, am I giving them dopamine as best as we can manage? Am I giving them an agonist that's activating the receptor, or am I giving them an enzyme inhibitor? You can sort of get an idea of, well, what's going to be causing what side effects, and what do we really need in later disease. So these are the 4 types of drugs here that I've tried to put on a table. And again, this isn't to remember, this is just to sort of give you a snapshot of what some of the drugs are called, and and sort of give you a bit of empowerment when you might look at somebody's MAR chart or drug chart or whatever. So L-dopa is giving the synthetic dopamine. It's the best, purest form of dopamine that we can give somebody. It's got the fewest side effects. And the trade names are cinnametamidopar or cocaryl-dopa and cobenal-dopa. All of the drugs have similar side effects. You can see I've highlighted here. They can make you nauseous. They give you low blood pressure. They can make you confused and hallucinate. And they all do that to a greater or lesser degree. As time goes on, they can give you sort of motor fluctuations by which I mean that off and on that we talked about in the jargon busting, so people can feel on, but then all of a sudden they go off, and they get sort of these swings in, on and off throughout the day. Or you can get these extra movements, so when the cells are being ultra stimulated, people are sort of moving a lot, but sometimes people would rather be moving a lot than not moving at all. Dopamine agonists, you can see the drugs there, so pramipexole, ropinirole and retigotine. These are drugs that you might have read about. They can cause impulse control disorders, so addictive behaviors, because dopamine is actually a reward chemical. So that's why we release dopamine when we take recreational drugs. So it makes us feel good. So sometimes when we have these dopamine agonists, which just sort of sit on lots of dopamine receptors in your brain, it can make you do funny things. And you have to be very careful to quiz people on this. So are you spending lots of money? Have you all of a sudden bought 5 cars that you don't need? And I have had a patient that bought lots of cars. They liked cars. And it's difficult teasing out, is that just their hobby, or has this now got out of control? So are they spending all their life savings and they can't really afford it? Gambling, hypersexuality. So it's very important to quiz people on this. Again, they can cause nausea, low blood pressure, hallucinations, and daytime somnolence, so getting sleepy. And then your 2 enzyme inhibitors there, so MAOIs and COMT inhibitors, again, can cause confusion, hallucinations, low blood pressure, nausea. You get the idea. So we've got symptoms, we've got our diagnosis. I told you about the clinic, in the hospital, and the drugs. So what are we contending with over time? This is how I sort of explain to patients about their condition. So you have this prodromal phase, which could be 10, 20 years, where you have these non-physical symptoms that are there. So people might have been depressed in the past. They might have this REM sleep behavioural disorder, so acting out their dreams. They might be constipated. They might not be able to smell. And then all of a sudden, once your dopamine cells are dying off, and once you've knocked off about 50% of them, you start to get the stiffness, the slowness, the gait problems. And you present to healthcare services and we make a diagnosis. And that's when you initiate your dopamine drugs. And then you get this wonderful phase for about 5 years where the drugs work and they go, doc, this Parkinson's disease isn't really that bad. And you can get people really good on their ADLs and they're mobile and everything is great. And then all of a sudden at about the 5 to 10 year mark, and that's obviously very individual, things start going wrong. So the drugs aren't working as much. They start falling over. You get urinary symptoms. Your blood pressure gets really labile. You get pain. You get these, fluctuations with the drugs. And then you say, okay, we're getting into the complex phase here, and you're going to have some trade-offs of what we can give you with the drugs and what is acceptable for, for your physical kind of health, etc. And then you get into the palliative. Along with that, as we've said, 75% of patients get dementia. So along with all of those physical symptoms, along come the mental health symptoms. And people say, I'm a bit more forgetful. I can't work the microwave. I can't work the washing machine. And a prelude to that is often hallucinations. Now, I've said to you that all of those drugs can make you hallucinate, but so can the Lewy bodies, and so is the start of a dementia. So teasing out what is the drugs, what is the disease, and what is the start of a dementia becomes very, very difficult. And so the way we would approach it is, okay, you're starting to get hallucinations, and it's often in the form of animals or people. So that, sometimes they are distressing, sometimes they are not. And so we'd say, okay, well, what drugs are you on? And so all of the drugs that are not that kind of pure levodopa drug have a tendency to do it more than that. So you think, well, can we stop anything here? But what are we stopping? What's the trade-off? If we start stopping drugs, you're physically going to be worse, but you might mentally be a bit better. So this is where the balancing act comes. And then when the drugs, despite all the drugs, things are not going well, we're entering into the palliative phases. And within our clinic, we have a palliative care physician that we work with. We have a psychiatrist that we work with. So it's very much a multidisciplinary sort of condition. So if you take nothing away from you, away from here, take away this, go away and have a look at the Parkinsons UK website and seek out this document, Occupational Therapy for People with Parkinson's, because I think it's brilliant. There's also a free webinar, I do believe, on the Parkinsons UK website that again is geared at therapists. It's a 15-minute sort of introduction to Parkinson's disease, probably along the lines of what we talked about, and probably summarising what's in that document. But go away and have a look. Parkinsons UK have great resources. Again, I direct all patients to there. So go away and have a look at it. But it's a very much an MDT condition. Within the hospital, we are more than happy to be approached by anybody about a patient that we're looking after, saying, look, struggling with this, what do you recommend? And we have regular MDTs to talk about patients and developments in Parkinson's disease and how we're going to, service improvement, etc., etc. So it's why kind of webinars like this are so important to sort of bring together that team and raise awareness. So I'm not a therapist. I work with fantastic therapists. And when I knew I was going to do this talk, I emailed our occupational therapist and our physiotherapist and said, what should I talk about? And also drawing on that document that I've just signposted you to, these are some of the things that the therapist came back with and said, right, okay, so you need to talk about stiffness. And stiffness obviously impacts walking, that's the thing we talked about, but simple things like bed mobility, so rolling over in bed, your activities of daily living, how you're transferring from bed to jail, whatever, and you're driving. So and driving is a massive thing for people that drive and all of a sudden then they can't, or we need to inform the DVLA, etc. Gait problems makes you fall over. I said you do those shuffling, shorter stride lengths, you become slower, and your gait speed is reduced. So what sort of things can we do to help? And I'll talk about that in the next slide. Your manual dexterity is reduced, so you're writing, doing up your clothing, feeding yourself. Communication because of your speech, and cognition. Now, I think cognition is the big one. You probably got that kind of impression. But one thing for carers that becomes really tricky is patients with Parkinson's disease become apathetic. So you become really flat. And trying to distinguish that between is someone depressed is very difficult. COVID hasn't helped because everybody's been socially isolated. And people become withdrawn because they might not be able to fulfill their role, whatever their role is within the family, and the expectations of that role. And you know, I often get carers in clinic just so frustrated, saying they just sit in the chair all day. They don't want to do anything. I can't get them to do anything, but I just want to go out. And that's almost what breaks the carers, is that sort of that apathy, but checking that there's not sort of a chemical depression behind there is so important. And you can almost divide the impairments into stages that we just talked about. So on that diagram with the early stages, the kind of diagnosis, maintenance, complex, palliative. So in early stages, our occupational therapist said to me, people often complain about problems with their handwriting, motivation, computer skills. In the mid stages, you've got difficulty preparing meals, your activities of daily living, and then the apathy that we just talked about. And then in later stages, care restraint is massive. You know, we just said that 10% of patients in care homes have Parkinson's disease, and this is why. Cognition, and the thing that often breaks people, not only the apathy, is the dementia and the behaviours that come with it. Couple that with some communication difficulty and swallowing problems, and you've got the perfect storm, haven't you? So we involve Parkinson specialists, nurses, physios, OTs, speech and language, psychiatry, palliative care, and more probably that I haven't mentioned. So things, you know, again, specifics are kind of beyond my expertise, because I do the medical bits and say, right, okay, this is what we've got, over to our MDT to try and help. But specific things that I mention in consultation, so fatigue, so patients complain of fatigue, a defined afternoon rest, sounds so simple, but giving people the permission to have an afternoon nap, that's okay. Performing single tasks, so stopping to try and perform lots of different things at once, making sure people have sleep hygiene. So again, sleep disorders, so we said that acting out your dreams is common. In about somewhere in the region of 30 to 50% of people have poor sleep. If you don't sleep well, your movement's going to be worse, you're going to fall over more. So getting people to sleep well and ensuring good sleep hygiene, ensuring reasonable bed mobility. So sometimes, you know, you can imagine that you're delivering those drugs to replace the dopamine, but can we give them a slow release one overnight to make sure that that's trickling in overnight and their mobility is maintained? Another fantastic one, so simple, is satin nightwear or satin sheets. Makes you a bit more slidey. Don't use both at once. Our physio in clinic said, please be aware of, because then you become too slidey. But just allows people enough to turn in bed. Bed leaves are helpful, but again, something that I was asked to caution you about is that because they encourage you to flex, that can often put you in the wrong position. So sort of bending and rolling can sometimes be better than using that lever to kind of pull yourself up. And again, ensuring the medications are optimal and we're not making this worse. Activities of daily living. So the tremor is often a resting tremor, but as disease goes on, it could impair how you're holding and doing things. So having a trolley to move things from room to room, travel cups that are going to mean that you're not going to spill everything, and hot drinks, and again, simplifying tasks so that you're just doing one thing at a time. Another tricky one for patients, and again, very much in the therapist court, is freezing. So these gait initiation problems and freezing. So lots of things that you can try. So auditory cues, so metronomes on your phone, or by your piano, or whatever you've got. So people start marching to the rhythm, or a good song that they can go to the rhythm. Get your feet going in time, do it on the spot, and then walk. And again, getting a carer to cue with them, so saying, right, 1, 2, 3, go, really helps, because it helps direct them on that task. Laser pointers, again, so walking towards the laser, sometimes putting floor markers on the floor, getting people to pace over them can be really helpful. But there's very specific interventions, and sometimes it's sort of all coming together and saying, well, what can we do? There's increasingly now these Zimmer frames that have got laser pointers on the front of them, and I think we had one lady that worked really well for. The other thing to be aware of, as we've talked about, is to target interventions to on periods. So work with the patient. When are they good? They'll know. they can tell, the patients become experts in this condition, and they will come into clinic and we work with them and say, you tell me when you're good and when you're bad, and we'll work with the tablets and see what we can sort out. And often I try and empower the patients to experiment with the drugs themselves, to say, look, right, okay, you're not good at 10 o'clock, so why don't you move that drug to 9:30 and see if that makes you better. Falls, we've talked about why you're going to fall. But, you know, look at the other things as you would do in anybody with, you know, chronic conditions. So look at the environment, the trip hazards, how are they calling for help, you know, targeted exercise, you know, sensory, vision, hearing, etc. The other thing that I know we do very badly in clinic, and we're getting better, is bone health. So people are falling, we need to stop them fracturing at the same time as well. You know, both would be ideal. So trying to do a FRAX or whatever kind of scoring you might use locally. FRAX is getting better. FRAX doesn't actually take account falls when you score somebody, or Parkinson's disease. But, you know, sort of thinking, does this person need some kind of bone protection with them falling, and checking a vitamin D in everybody and making sure they're all on vitamin D is a good idea. And then, you know, from a disease modifying point of view, have we got the drug balance right? Are people becoming very off, and that's when they're falling? Are people becoming very on and dyskinetic and wiggly, and that's when they're falling because they've got too much movement? Are we giving them too much dopamine? Their blood pressure plummets when they stand up and then they fall over. So it's looking at all of the different kind of you know, facets to the presentation. And then I think this is my last slide actually. So Parkinson's is a neuropsychiatric diagnosis. I once had a very sad sort of interaction where I said to somebody, you've got Parkinson's disease, I'm very sorry to tell you that, and we'll talk about it. And they went, oh goodness me, thank goodness you didn't tell me I had dementia. And you went, right, yeah, no, now's not the time to broach that. But we've said that 75% of patients get dementia. Hallucinations are a prelude to that. It doesn't always mean that they will go on to develop dementia, because we know that the drugs cause it. We know that it's on the spectrum of Lewy body dementia. You can get psychotic depression where you can hallucinate. So teasing all these things out are difficult, but we know that people get anxiety and depression along with all of this. And this is what leads to care restraint. It's often the physical bits we can often sort out. It's the mental health bits that become really, really tricky. And this is often why patients end up in long-term care. And I spend most of my clinic saying, now we're trying to decide on optimizing the physical symptoms versus the mental health symptoms, because the drugs, they're causing mental health side effects, but they're helping you walk. And it's actually, you know, teamwork between, well, what's your threshold, what's your trade-off, how can you tolerate the hallucinations versus the movement? And sometimes if people's hallucinations are actually reassuring or quite comforting and not at all distressing, you would probably accept that they continue to have a low level of hallucinations but be mobile. For some people, if the hallucinations are very distressing, then you're going to have to tail back some of that dopamine treatment, but probably at the expense of their physical movement. It's not quite my last slide, this is my last slide. So end of life care. So I said that there's this, you know, this kind of timeline of complex phase into your kind of palliative phase. So Parkinson's disease, it is essentially a terminal. Is it a terminal diagnosis? I said something controversial. It is a chronically progressive condition that if you live long enough will probably lead to an end-of-life scenario. But as I've said, we can probably give people 10, 15, sometimes 20 plus years of good quality of life. So it's not a terminal diagnosis, but it is a chronic and life-limiting diagnosis. And when we get to the end-of-life palliative phase, because the receptors for dopamine have died off, the drugs are often causing more harm than good. And that's often where actually you're reducing the drugs and taking the drugs away, and then focusing on perhaps your anticipatory medications for end of life that you would normally use, rather than sort of specific Parkinson's interventions. So that's me. Perfectly happy to answer questions. And I also said that I'm happy to, if there's anything burning questions, I'm happy to be forwarded questions on if there isn't time to cover them now. So I'm going to stop screen sharing, assuming that I do this right. There we go.
Well, that's really fantastic, Laura. There's so much to take in and take away. Tribute to what you've gone over. There's a lot of questions, so I guess we just get rolling straight into those, if that's all right.
Okay.
So we had some before the session. One about probiotics. How do probiotics work to alleviate symptoms? It sounded bizarre to me, but Barbara Thompson, the jazz musician, said she could play a flute again. Does it only work for early stages? Should I be mentioning probiotics to my service users who are generally well advanced with their Parkinson's?
It is not, if I'm being honest, it's not something I'm aware of much evidence base behind. Whether it helps then improve your gut motility that then helps the drugs work better is possible, because if you're constipated, the drugs basically stagnate in your stomach and don't work effectively. So actually, rather, what I do, there's lots of people who come in and say, oh, I've got probiotics, so I bought this like extract of broad bean off the internet. There isn't really the evidence base behind them, but simple things like making sure they're not constipated with our usual stuff, I think is more important than actually, flagging them to specific things. And I'm always wary at kind of patients spending a lot of money on things that don't have evidence base.
It's helpful. Question from Anne, is there any benefit to obtaining an early diagnosis? Quite a few questions.
Yes. Yeah, there is. Yeah, absolutely. So the jury was a little bit out on this in past, and actually they used to say, reserve drugs until you're really symptomatic. But actually what we've now discovered is if you treat patients early, or actually reverse that on its head, if you hold off and don't treat patients, they never quite get up to the same functional level as those that were treated early.
Following on from that, Amanda asks, what is an effective treatment activity for early diagnosis? So an effective treatment or activity.
So the treatments are all the dopamine related drugs that we talked about, and it's the same in early stage or later stage disease. The importance is from a sort of a physical activity point of view, it's keeping moving. And we've got, our therapists do, specific warrior type strength and balance training and things, and they would be better advised on what specific programs there are. But the best thing is just to get people moving and continue to move.
Great. One from Seema here, and it was helpfully answered by some other colleagues, so thanks for the interaction in the chat. So Parkinson's caused by genetic mutation. Many relatives of Parkinson patients ask if this disease runs in family. So
I usually say, as a rule, no, it doesn't. So they don't. So if, say, you've got a mother or father with Parkinson's disease that developed it in their 60s or 70s, might put you at a slightly higher susceptibility for it if you had all those environmental exposures. But they don't need genetic testing, and they don't need to worry about their children or their children's children. It's when you're getting early onset Parkinson's disease in your sort of 30s and 40s, and they've got a first degree relative, you had a first degree relative, that you would do gene testing. As a rule, it will just increase your susceptibility slightly, but not dramatically. All of our risks are the fact we're all getting older and living longer.
That's helpful. I think that falls on nicely to Lorraine's question. Are there now tests that diagnose Parkinson's rather than just looking for the common symptoms?
No, there aren't. So still no one specific test. So as I explained, it's a clinical diagnosis, perhaps with a supporting dopamine scan, the pretty picture scan, plus or minus an MRI, but neither of those are necessarily diagnostic. It really comes down to your clinical judgment and then how you respond to giving them dopamine.
That's great. One I'll take here from Susanna, wanted to do a session with a client and rep for the Lento Rise Recline chair. Would it be available to order as a special from Mediquip Lewisham? That's absolutely fine, and that's exactly what we do. We can come out with the equipment and then present the quotation to Mediquip. We deal with them a lot. Just to reiterate, we are sharing the PowerPoint because there's a lot on there. I'm just flicking down to the next questions. We've got one here. From Anne, I have to use trial and error to find out if motorized equipment like powered stand aids will work or will conflict with the customer's own movement. Is there a way to assess and predict rather than resort to trial and error? I'd be glad of your thoughts on that, Laura. Have you had much sort of dealings with equipment, or is that more really falling with the therapist role?
I'd be the wrong person to ask. Because that really would come down to the individual therapists that are dealing with that aspect. Other than I have therapists saying to me, look, is there anything you can do to optimize this patient's on time first thing in the morning when the carer's coming? So it is, it's an MDT approach, and likewise I've had care agencies on the phone saying, look, can we just look at this person's medication, see if we can fit it in with the carers, the carers timings, etc. But to be honest, a lot of what we do with the medications as well is trial and error. So sometimes it is just trying to find that fit for the patient.
Yes, yeah, I think that's really helpful. It's not a golden rule. There's to do with timings and environments and the therapists who know the clients best. Question from Claire. I know it is more prevalent in older age, but is there any difference in the disease of those who are diagnosed at a relatively young age?
No, there isn't. Other than, if you are already 70 or 80 when you're diagnosed with it, the likelihood of your Parkinson's being your life-limiting condition is probably much less than if you're diagnosed in your 30s or 40s, and you know that you can get maybe 15 years of good symptom control. That puts you at 45 or 55, which is still not old.
That's great. And a question from Sonia here, which I think you touched on. Can a brain scan show areas of damage in the brain if this has occurred? Does that really take us back to your slides?
Yeah,
when you were showing?
Yes, an MRI or a CT would show damage from other things, so strokes, shrinkage of the brain related to age. It doesn't sort of show the death of the cells related to Parkinson's disease, which is why there isn't still one good test for it.
Great. And question from Rashid here. What factors are responsible for having Parkinson's disease more common in men than in women?
Good question. It's literally about 1 to 1.25, so it's almost equal sex distribution. It's ever so slightly.
Yep. Okay. More of a local one here from Trish. Does a community nurse only work in Nottingham City or across Nottingham County?
Yeah, no, only Nottingham City. Yeah, somebody obviously working locally. We're looking at that. We're hoping we did used to have a Parkinson's nurse in Nottingham County, and unfortunately they were decommissioned, which I think is terribly sad. That was about 5 years ago. We've got a big load of Parkinson's work, so it's ongoing work, but I think it's going to take a while to make a business case.
Sure. A question from Seema. Is there a diagnostic screening tool for the early detection of Parkinson's? I think we've touched on that, but many at times I've noticed postural hypertension are managed but not connected well within Parkinson's diagnosis. Can patients get absence of other Parkinson's symptoms but just orthostatic hypertension?
So older people can get orthostatic hypotension without having Parkinson's disease, but then people with Parkinson's disease are more prone to that. And also there is as I talked about the spectrum of Parkinson's disease, people with Parkinson's plus syndrome, so multi-systems atrophy, have very few physical symptoms of Parkinson's but have bad autonomic control. And what we now recognise is that there's these sort of subtypes of Parkinson's disease, and some that get really bad blood pressure problems, some that get bad dementia. So we're still learning, but older people can get it without Parkinson's.
That's great. And question from Sonia here. Apologies, Laura, if these have already been answered in your presentation. I was trying to listen out as we're going through. Does the medication slow the progression of Parkinson's?
No, it doesn't. It's not disease modifying, so it doesn't slow the progression. It just makes the symptoms manageable.
And an interesting one here from Imran. Does any scientific evidence available for dietary habits can fight the Parkinson's disease?
No.
Is it true that music can help patients with walking pattern?
Yes, definitely. Rhythmic music, you know, keeping in contact with the beat, absolutely, yeah.
Yeah. One I might try and answer myself here. Is it advisable to assess patients with Parkinson's disease for powered wheelchair? And feel free to jump in, Laura. What I would, of course, it's each person, isn't it? It's how their Parkinson's has affected them. You can program down to a very slow speed the power wheelchairs, and there are different control options as well. So I guess there's probably not that rule, unfortunately, but it's a case by case, really. It's assessing somebody's cognitive ability. Don't know whether you've got anything to add on that, Laura.
Keep them walking.
Yeah, keep them walking really to the
yeah,
as far as they can. Is there any link between ADHD and development of PND? Just wondering, as ADHD is due to lack of dopamine.
So yeah, ADHD is related to dopamine. It's not an area of my expertise, so I'm not sure on that. But dopamine has got a lot to answer for a lot of neuropsychiatric problems.
Okay. Are they able to meet the DVLA standard for driving a vehicle?
Yes, you can. So as soon as they get a Parkinson's diagnosis, you have to inform the DVLA, and then we get a questionnaire sort of asking about off and on periods and fluctuations with their drugs and cognitive function, hallucinations, etc., etc. But in early disease, absolutely, people can continue to drive. The two big things are when they start to get motor, so physical fluctuations that mean that you're probably unsafe, and then also the cognitive impairment. So again, as therapists, some of you could probably answer that better than me, but my understanding was once you're getting sort of mockers below 18 out of 30, that they would be unsafe, and particularly when you're doing clock drawing and those intersetting pentagons, if they can't do that, then you need to really worry about whether or not they can operate a car.
Thank you. Question here from Imran relates to milk products. If I've understood the question right, am I right in saying generally avoid those with Parkinson's disease?
So protein containing foods can slow down your absorption of the drugs. So I guess milk is a bit of sort of protein related drink, isn't it? So as a rule, no. There are a small selection of patients that say if they have a really big protein meal that their drugs don't kick in. But they are few and far between. And some of these patients end up on 5 times a day, 6 times a day drugs. And if they're trying to distance them from food and milk and everything else, they just don't know whether they're coming or going. So I often just say, take them when you remember them. And then if we start to run into problems where they're not working, then we look at what you're eating and what your diet is.
That's great. Question here from Claire. So going back to walking aids, do walking aids increase safety whilst mobilising? I have experienced patients who report that walking aids are more of a hindrance than a help.
Sometimes, again, individual. As a rule, sometimes the delta frames of the brakes are good because it gives patients sort of that kind of autonomy of when they stop. But again, the problem is if they have to activate the brakes, and they've got that tendency to run, and retropulsion is that can run away with them and over they go. So it's very much an individual thing, and again, cognition gets in the way. So trying to get somebody to use a stick and sort of coordinate that with their gait and perhaps the side that isn't working so well, if they're cognitively impaired, can become a problem.
Some interesting ones we've had is that you can get what they call the slow down brakes, so that can help with the walker running away from them. I think I'm right in saying some have laser beams as well, which really links back to your presentation in terms of, I guess, training. And then we've also had quite successful with the gutter frame to, really, I suppose, down to somebody's gait and how they walk. But yeah, it's really.
Some people, when they get very stooped, so I've got one lady, with essentially a bent spine. We've got it's called camptocormia, and sometimes people get what we call Pisa syndrome, so they become very bent sideways. A gutter frame has been quite helpful for her because it gives her sort of the ability to stand up, but getting one was an absolute nightmare.
Okay. interesting one here from Amanda. What is your experience of boxing as an intervention?
As what, boxing?
Yeah.
Nothing. I don't think I've got anybody that boxes. We do have locally, our Parkinson's Nursing City is doing a trial on Nordic walking. That it's being trialed at the moment. I could just see that somebody's just said, what's a gutter frame? It's a frame that's got like rests for your forearms and sort of handles that allows you to kind of sort of stand more upright. Apologies if I've said that wrong. And again,
No, that's great.
Not a therapist.
Question from Tracy here. Any strategies for managing apathy?
Oh, I mean, it's a real nightmare. I think ensuring that they're not depressed, trying his best to engage in sort of social stuff. So the PD UK groups are really great. Regular naps, checking that they're not fatigued, making sure that the drugs are optimal. Yeah, that's always what we can.
That's really helpful. Well, there's many thank yous. I will apologize now if I miss your question. We'll try and comb back through those. Really appreciate your time today, Dr. Laura. That's been really helpful. A lot for me to take away, a lot of learnings there, and yeah, tribute to how interactive that chat has been today. There's been a lot of questions and a lot of learnings, I feel. So if we've missed your question, apologies. We will flick down them and reach out to you. And just a real big thank you, Laura, to you again for coming on. It's fantastic to share your experience, your learnings, your knowledge, and really a big thank you to all of you. There's been many on the call today for sparing your time. Trust you've enjoyed it. Trust you got something from that, which will help you with your patients. And just on behalf of Yorkshire Care Equipment, if there's anything that we can do to assist, feel free to reach out to us. We've got a particularly useful section on our website, free resources. There's ebooks that we've written. There's justification templates, things really to aid you as if you're a therapist, to aid you with equipment provision. So thank you very much once again, and have a great rest of the afternoon. Thanks, Laura.